Welcome to Massey College. My name is Jonathan Rose. I'm the new acting principal of Massey College, and I'm delighted to be here and excited to hear this coming dialogue on a very important topic related to substance abuse. Let me acknowledge that Massey College is built on land where Indigenous peoples have lived. It is on the treaty lands and territory of the Mississaugas of the Credit First Nation, as well as the traditional territory of the Huron-Wendat and the Haudenosaunee peoples. We want to acknowledge our duty of stewardship toward the land and the great privilege that we have to work on this land. This is going to be a really fascinating discussion around substance abuse and how to manage it. It's actually something I work a little bit on in my own research, and so I think it's a wonderful thing. I won't be hosting it. It'll be hosted by Satesh Yazdani, and let me tell you a little bit about her. She's a first-generation Iranian-Canadian student who is studying for a Doctor of Pharmacy here at UofT. She completed her Bachelor's of Toxicology and Master's of Pharmacology at UofT as well. She joined the Canadian Armed Forces Regular Officer Training Program with the aim of becoming a military pharmacist. She mentors young students and is very passionate about healthcare and community work. Over to you, Satish.
Thank you so much. Okay.
Actually, you have a laptop.
Yes, I think I don't need that. Okay. All right, thank you so much, Principal, for that remark. I want to say hi to everybody who made it here today, the audience, also the audience online. Thank you for making it, and also our panelists. Thank you for taking the time out of your busy day and schedule to make it to the panel discussion that I'm personally really passionate about. As you know, substance use disorder is on the rise, and it's a public health issue that has been happening in Canada, and it's something that we see if we walk around Toronto every day. We see people dealing with opioid use disorder. We might see even people overdosing. So I thought it would be such a timely topic for us to be exposed to, and hopefully out of this conversation today, you leave this session inspired to learn more about it and even maybe help your community in some way. Thank you. All right, so I want to do a brief introduction of our panelists today. I'll start with Dr. Akwasi Owusu-Bempah. Akwasi is an associate professor in the Department of Sociology at the University of Toronto, and also he is a senior fellow at Massey College. He holds affiliate scientist status at the Center of Addiction and Mental Health and serves as a director of research for the Campaign for Cannabis Amnesty. Akwasi's work examines the intersections of race, crime, and criminal justice, something that we will touch at some point during our conversation today. He also studies various aspects of drug legalization in Canada and around the world, and he publishes regularly. There's some about his background, but just saying that I think we have such a great panelist to join us today and provide insights on that topics that I shared with you. Next, I would like to introduce Dr. Tianna Costa. Tianna is a clinical pharmacist, and she earned her Doctor's of Pharmacy degree at UofT, and she completed her residency at the Center of Addiction and Mental Health, CAMH. Currently, she serves as a clinical pharmacist at CAMH, and she specializes in the treatment of concurrent disorders. And in her role, she operates within an outpatient clinic and offers medication therapy management as part of an interdisciplinary team. She's also the pharmacist on the Addiction Consult-Liaison service at CAMH, so we think that she brings a wealth of knowledge in terms of her job as a clinician at CAMH. Next, I would like to introduce Dr. Michael Chaitan. Michael is a senior scientist at CAMH as well. He works specifically within CAMH's Institute for Mental Health Policy Research. He's a director of research at the Ontario Tobacco Research Unit and associate professor affiliated with the Dalanana School of Public Health and Institute for Medical Sciences at UofT. Also, Michael earned his PhD in epidemiology from the University of Toronto, and he's the co-director of the Collaborative Specialization on Addiction Studies. So, as you can see, we have three experts in the field, obviously all come from different backgrounds, but I think that's going to what's make this panel discussion very interesting. I'm hoping that together we can ask interesting questions, but just to start the conversation, I thought to start off with the first question, and I'm going to ask Tianna if you can define for the audience and everybody here, what is substance when we say substance use disorder, and are all substances bad? Yeah.
Yeah, I think that's a really good question. So when we talk about a substance use disorder, we think of like substance use or continued use despite harm. And so when I teach it in school and in lectures, I talk about kind of the 4 C's. So we see continued use despite consequences, so that's 2 of our C's, cravings, and compulsion to use. So that means that when people are using substances, it's not all bad. And so sometimes you can think of it on a spectrum where some substance use might actually be beneficial. So thinking about, people using tobacco in spiritual ceremonies, people using opioids for pain control, like these all have benefits. But along that spectrum, some people's use becomes problematic. And so sometimes you'll see people who are binge drinking at parties or using cannabis and then driving. This is starting to become problematic. And then kind of further down and probably right at the end of that spectrum is when someone's developing a substance use disorder. And so this is again where they're continuing to use despite having, psychosocial harms, psychological harms, or harms related to their jobs, their families. And so I think it's important to note that just because someone is using a substance doesn't mean that they have a problem with it. Not all substance use is bad. And some people, like I said, derive benefit from it, or people are able to use and control their use, and it doesn't actually cause a problem in their life. And so I think there is a big differentiation between substance use and then a substance use disorder.
Thank you. I think that was very comprehensive, and I think it's a good way to start the conversation so everybody's on the same page. When we talk about substance use disorder, what are we talking about? I wanted to ask this question because for me it's important to have an idea of how does somebody, what is the trajectory when somebody starts using a substance? At what point does it become a disorder? And if you can paint a picture for us, and I'm going to direct the question to you in terms of social factors. I know you work in intersection of studies related to race and socioeconomic factors. What is the risk in terms of population if you look at across Canada, for example? Who's at risk of substance use disorder?
I will probably deflect at least some of this question to the other panelists, but I think it's important to note that there are a multitude of trajectories to substance use disorder. There's no one linear pathway. And so, many people would look at adverse childhood experiences and the trauma emanating from those, for example, abuse, neglect, and the likes as being potential risk factors for substance use disorder. Of course, when we look at, you mentioned the opioid crisis off of the top, and we look south of the border, and the number of people, for example, who might have become addicted to opioids as a result of an injury and the prescriptions that they would have initially received from their doctor, and then no longer being able to obtain legally the painkillers that they were using, and then or developing addictions, and then certainly turning to unregulated sources to get their substances, and the problematic use and the at times dangerous use persisting from that. So I will again. I know that the other panelists will have much to say here.
Dr. Chetan, I want to direct the same question towards you because I do know that you work specifically, your research is focused on adolescent population. So a lot of the use starts in that age group. So what puts an adolescent at risk? And if you can just go over that.
Sure, and I think this is really an important consideration when we talk about substance use, is that there are different elements of the pathway and the trajectories towards a substance use disorder and different factors that are associated with each step along the way. And from my perspective as an epidemiologist, the most important is the initiation, the time where you take that first use of the drug. And that's the point in time which we see the most factors that are associated with. And there are a host of different things from those associated with the individual, your genetic susceptibilities and vulnerabilities, the way that your biokinetics work in your body, towards the way the pharmacokinetics of the drug itself. Well, that's a little bit later, but the interaction is there. But also, it's most importantly about the environment. What's the availability of that drug in your environment? How common it is among your parents, your peers? How easy is it for you to be able to access that drug? And those are, and what kind of promotion essentially, how do you know about the drug in the first place? There are thousands of different kinds of drugs and substances that we've used over the course of human history, but really only a few of them are at any way popular at any point in time. And so those are popular for a reason. And I would say the main the first step in substance use disorder is being exposed, and that's where for me, at least personally, I would put the sort of the issue of causation on. And then once you've tried a drug, then there are a host of other factors that are associated with who's then susceptible to becoming more addicted, to escalate their use, to have problems when they try to stop using if it does become a problem. So, and those, I think, as Kwasi mentioned, the ideas of trauma and vulnerability, as well as sort of the genetic factors associated with the interaction with the drug itself.
Thank you. I think that was very comprehensive. So there's a lot of factors from the environment, also genetic factors. So it's very complex what I'm hearing, right? Okay. So imagining somebody who started using a substance when they were maybe in high school and they got exposed to it. And now, like, fast forward, I don't want to use the word addiction. I kind of don't like the word. So they have substance use disorder. Can you go over what are the stigmas? Like, if you imagine this person in your mind, what are the stigmas a person would be facing in our society, somebody with substance use disorder? And I think I want to start with Tianna, because you work with patients like that on a day-to-day basis.
Mm-hmm. I mean, I think there's many different types of stigma, and I think one of the most powerful ones is the self-stigma. It's like what people feel about themselves related to their substance use disorder. Feelings of guilt, feelings of not worthiness, feelings of, it's their fault, when we know that there is a host of factors, as we just discussed, that make a person, even begin to develop a substance use disorder. And then when we think from like a societal level, and especially in healthcare, there's so much stigma associated with this. And so when people come into the hospital, and there's studies that demonstrate this, they're treated differently. A lot of times if they come in and they have a prescription for something to treat their addiction, a lot of their other health concerns will be dismissed as being related to their addiction, and a full workup is not being done. And so you can imagine kind of that distrust that starts to happen within the healthcare system, and so then being able to seek help for their substance use disorder becomes nearly impossible. And so I think, I work at CAMH, and so we see clients who are coming into our facility, but that's one subgroup of people who are even able to come through our doors. There's so many people who are not willing to come into hospital, and so I think we'll talk about eventually, these low barrier clinics, these supervised consumption sites, and sometimes these are where people are able to access care because they feel that these barriers of the healthcare system don't exist.
Yeah, that's a really good perspective. And would you like to add to it, either Dr.?
Yeah, and I think one of the issues is that stigma is a complicated thing. And stigma, I think, is some of it, I think, comes from sort of our human dynamics, is that we use stigma in order to identify behaviors and things that we think are wrong. And stigma is a way of socially managing that. And so that self-stigma, that stigma from feelings from other people. And so a lot of this is driven by our sort of perception of drug use as bad in some way, as wrong. And I think a lot of the ways in which stigma flows comes from that perspective of that this is something bad, and people who do bad things are therefore also bad, in a really simplistic way of putting it. And so I think that makes stigma really challenging, especially when we are trying to treat people, and I think in a clinical setting, to me, the answers seem more clear, that it's not actually we are trying to treat drug use or even substance use disorder necessarily at a clinical level. What we're trying to do is help people feel better. And that doesn't necessarily have anything to do with their substance use. They may still be able to use substances, they may be able to want, or it may be substances something that they want to address. But from a clinical perspective, I think that answer is really clear. We just need to see the person in front of us and be able to treat them. From a larger society perspective, we get into a more complicated situation, right? And it's there is certainly much about substance use that we do think of as having negative consequences, that people who use substances think of having negative consequences and want to stop others from sharing those consequences too. But I don't know if we've dealt with that as humans to be able to figure out how we set those parameters of the way that we want to communicate how people should behave and not have that leak into our treatment of people as individuals and the way they actually behave.
And this is something that, I observe very clearly in my work, in thinking about stigma, or the differential stigma attached not only to substances, but to people who use substances. And then there's, this interaction effect between the type of substance and the type of people using. So there are people who have, serious dependencies and addictions to substances, and their use and their problematic use is not seen and not stigmatized in nearly the same way as other populations. Things are changing undoubtedly, as they do in this arena, but you can think about the heavy drinking in certain occupations and associated with certain activities. So whether that be varsity sports teams, for example, and the heavy drinking that hockey teams have often engaged in. You think about certain professions. I study criminology, policing. Serious and heavy drinking, problematic drinking, has been a feature of policing for a very long time. But that problematic use and what flows from that, including not infrequently police officers being arrested for impaired driving, sometimes after leaving the police station, is not looked at in the same way as someone who's more marginalized using a substance, which again has problematic outcomes for themselves and for others. And so the stigma aspect of this, for me is big. And Michael, I like the point you made about we stigmatize behaviors we feel are wrong or are bad or are damaging. We also criminalize those as well, of course, right? And this interaction between stigmatization and criminalization, and then the seeking of treatment is key as well. Because how many people are reluctant to seek treatment because of the criminalized status and the stigmatized status of what it is that they're dealing with. And this criminalization aspect is key in my work, because we often criminalize individuals who are also stigmatized for what they're doing, stigmatized for their substance use and for other reasons. And that can contribute to, as I think has been noted, even more problematic behaviors.
Thank you for that, Akwasia. And I think that's an interesting point to bring up. And I wanted to ask a follow-up question regarding the crime aspect, right? It's like, if I do something like this, I might get into the jail. And for me, from my perspective as a pharmacy student, I think I'm going to be a clinician, so it's like helping somebody, right? But like law enforcement, how do those people view people with substance use disorder? Because we learn in our program, in clinical programs, it's all about compassion. Right? But then is there the same perspective, or is there a stigma? Let's say a police officer, if they see somebody got in trouble, if they realize this person has an opioid addiction, are they going to see this person differently and maybe not be as much, invested in helping someone? Is there that?
Well, I think I wouldn't want to paint all police officers with a single brush, and I think there are different approaches to this very issue that are taken not only by individuals within police agencies, but even by entire police agencies or parts of police agencies. And I think historically, again, we've seen a very harsh and enforcement orientation towards drugs and the people who use them, and that in some areas is certainly waning. And so many police officers, I think historically, would have looked at drug users as bad people because of the association between their drug use and its illegal status. Right. Police are by the very nature of their job, tasked with enforcing the law, and these substances are illegal, and therefore the people using those substances are painted, are grouped with other categories of people who break the law. And I think that's part of the problem that we're trying to get out. Now, with that said, I've interacted with police officers on an individual level and seen approaches to policing that are much more compassionate. And again, I think that we need to recognize police officers themselves as representing a diverse group, and there would be many who would have their own personal or vicarious experiences with substance use disorders and addictions, who would understand the nature of the problems that the individuals are facing. And so again, you could look across not only the country, but in different parts of the world to the vastly different approaches that police agencies have taken towards people who have substance use disorders. Again, I think we're primarily operating from the enforcement standpoint, and that enforcement being associated with the negative perceptions and the criminality of the behaviors that these individuals are engaged in. But again, thankfully, we're starting to see a shift.
That's interesting. And I can think of substances that it would be illegal to use, right? So like if fentanyl people, if they're using it for valid indications and reasons that we learn in the program, in pharmacy we learn people use it for pain, that's valid. But then at some point if, they start using it and diverting the patches, I think that's when it becomes really a problem, and I think it's a criminal issue at that point.
And if I can add, even thinking about this shift, because I was kind of chuckling last week reading, cannabis is legal now, and so people can possess it. Historically in this country it was criminalized, and there were periods in which, again, penalties associated with its possession and trafficking were much harsher than they were prior to legalization, and people were actually incarcerated for simple cannabis possession. In the period leading up to legalization, that wasn't the case. But you would have had, again, and I'm thinking about law enforcement here, organizations, agencies, agents who would have taken this very kind of criminal approach to people using cannabis and possessing cannabis. And I think that, again, the interaction affects certain subpopulations, so young people and certain racialized and marginalized populations, their use being looked at in an even more negative light. And I raise this simply because there was a new directive that came from the RCMP just last week or the week before around the kind of guidance that they're giving to officers and their consumption of cannabis off duty.
Okay.
And so, you've got this, we're talking about law enforcement and we're taking a previously illegal substance, one that's now, legal under certain circumstances, but just talking about that kind of shift in approach and in mindset, and the RCMP, kind of loosening up their guidance with respect to their members using cannabis.
And regarding cannabis, if you just go back, I think it was 2018, correct me if I'm wrong, that's when it became legalized. So prior to that, there was a huge stigma, right? And then we saw a huge shift. So I just, and I think maybe this question can be directed to you again. What would happen if the label of crime is taken away from drug consumption?
So that's what I would like to see happen in the future. I would say that I think there's still a fair bit of stigma attached to cannabis and cannabis use. And again, it would relate to the type of cannabis being used, whether one's smoking it versus using some kind of edible or a topical, for example, and the subpopulation as well. Undoubtedly, the stigma has decreased, and I think the law, in many ways, was trying to catch up with the changing social attitudes. The law was trying to catch up with the changing social attitudes towards cannabis. Canadians had long been in support of legalization. The law took a couple of decades to catch up with that reality. So, there's that nuance to it. I think it would take a long time for social attitudes towards certain substances, in particular things like heroin and even cocaine, but certainly heroin. Again, you've mentioned fentanyl already, that can be accessed, by many legally. I think social attitudes would take a fair bit of time to change with respect to those substances. And I think we would continue to see a lot of stigma around people who use those and have problematic relationships to those substances. But again, I would like to live in a world where none of these substances were illegal. They were, heavily regulated if they were dangerous to individuals and to the public. But it is this kind of societal shift in mindset. Is it the substance that's problematic, or is it what we do around the substance that's problematic? And I think that gets back to your point about helping people become well and managing their relationship with the substances that they use.
That's a great point, and the point about regulation. And I want to ask a follow-up question about regulating drugs, because that also changes the market, right? You saw that with cannabis, now it's legalized, so people can actually go to stores and buy, and they know what they're getting, right? And Tianna, you talked about this to our class, about the illegal market and what happens. If you can go over that, and especially the problem with fentanyl and all the other drugs mixed in, and people are getting exposed, and maybe that's a problem with the opioid crisis and some of the overdose. If you can give some perspective about that. Yeah,
I think we've talked about how criminalization of substances has led to an unregulated market, and especially now where it's very difficult to bring drugs across the border. We just see super potent versions now of opioids being brought over and mixed with multiple different substances, multiple different sedating agents. And so it's making the reversal of overdoses a lot more difficult because not everything will respond to naloxone. And I think that this is well known now, that we know that criminalization really fuels this unregulated market. And so when we think about how, you can go to an LCBO in Ontario and you know exactly what you're getting, you can go to a cannabis store now and know what you're getting. But for all these other substances that really do affect marginalized communities, we see that these are the people most affected by this unregulated market, and we're continuing to fuel that. And if anything, it seems to be getting worse and worse. And so right now, in Toronto, we have the Toronto Drug Checking Service. And so every couple of weeks, they send out an alert of what's in the supply. And sometimes it's really mind-boggling how many different types of substances are in it. And then, the number of overdoses that are associated with the different products that people are using, the ones that are not responding to naloxone, et cetera. And so we're seeing the consequences of this unregulated market. We're seeing this rise in overdose deaths that's just continuing to rise despite, I think this really kind of taking a hit in 2017, and we're now in 2024 and we're still seeing this rise. So it's not getting any better.
Yeah. I don't know if it's right to say, if I'm going to take away a message from, the points you've made, definitely taking the label crime might help going towards a positive direction, but it might take some while for the stigma to be resolved from the society. It's not going to be a change overnight, even if the government says this is not illegal anymore, right? So we have to do some work.
Well, and I think around the criminality aspect, again, going back to the seeking of treatment and dealing with what comes from the stigma related to people accessing treatment and for the availability of treatment, not only because people are unwilling or less able and willing to do so because of the stigma, but also because we spend resources on law enforcement that could be going to treatment. And then the other part of the criminalized aspect that I think is important for us to recognize is what the criminal market entails and what it allows for, right? Part of it is its unregulated nature, allowing for all different kinds of substances to end up in the drugs that are available on the street, so on the supply. But we can't forget that those involved, especially the more sophisticated entities involved in the trade of illegal substances, reap huge profits to the tunes of billions of dollars a year from engaging in this trade, which they can then use to fund other enterprise, which can have an even more negative impact on society, right? Many of these sophisticated organizations are also involved in human trafficking, in arms trafficking, right? In a host of different criminal activities that the drug trade helps to fund. And so we, again, in thinking about this, it's not that legalization and regulation would deal with all of the problems that we see. There are very serious issues related to the use of these substances, but we have such a barrier to addressing those issues due to the criminalized nature of many substances.
Okay, thank you for that.
I mean, it goes a little bit into what problem do we want to solve? And I think it's clear, and I think it's actually inevitable that criminalization of individual behavior does not solve any of those problems. That the reasons why people use substances is downstream of the reasons why we have substance use issues in our society. And so that penalizing people for happening to be on that end of it at best it might be putting a Band-Aid on the situation, but you're not stopping the flow. And so I'd say I maybe even more optimistic than you, or optimistic is maybe the wrong word, but I think that there is essentially a slippery slope with legalization. And we're starting to see more and more places. We do have, there are countries now that do have recreational cocaine, for instance. We see decriminalization in BC. And I think the moral argument against criminalization is really strong and eventually very compelling. The issue that we still need to deal with is around what the problem is itself. And that when we think of a country like Canada, the drugs that cause the most death and disease are the legal ones. tobacco and alcohol in particular. And the reason why I would argue that they cause so many problems is because there's the commercialization of those products, and there are corporations essentially exploiting and profiting off of people's addictions.
Right.
And so I think when we talk about legalization, we should be really careful not to jump straight to commercialization. Because both, I think, in a legal sense, you just talked about how the billions of dollars in profit, that's essentially a commercial market, black commercial market, exploiting people's addiction is not that much, I think, is a crucial component of this.
That's such a good point, because I think when we think of substances, like substance use disorder, I don't think people would think of alcohol. It's so accepted socially to be in parties and gatherings, and obviously we talked about the fact that substance use is not always bad. Or tobacco, like I think it's so common in some cultures too, right? So, yes.
Let's follow on for this, because I think the harms is a key one, and I always reference David Nutt's work, but others have done this, assessing kind of the harms and risks of substances, various substances, both to the individual and society. And correct me if I'm wrong, but I'm almost certain it goes alcohol, heroin, tobacco, or is it alcohol, tobacco, heroin, in terms of, and the assessment is the harms these substances have to the individual and then the harms to society. Alcohol obviously very harmful to individuals and harmful to society in a multitude of different ways. Tobacco very harmful to the individual. But what's very interesting when you look at this assessment is something like psilocybin, which is currently illegal, comes down, like it's in and around, and I may be exaggerating a bit, but coffee, right? And again, when we think about substances, I could go to the LCBO this way or that way and buy one bottle of alcohol that if I drank the whole thing, I would be dead, right? We have access to those types of substances, or if I drank a third of it and I got into a car, I would be at a pretty high risk of injuring others from an accident, right? So when we think about, and I think this is part of the important piece around the stigma, is not to diminish the harms of any of these substances, but to recognize the kind of inequity with respect to societal perceptions, of different substances based on their current legal status.
Yeah, and I think there's a cultural piece to that. Coming from the east side of the world, I grew up in a country where alcohol was not legal, so that was never a problem, or at least people would hide it.
But I'm guessing that opium use was probably not that unusual.
Yes, but again, and I saw my grandparents, it's really interesting to think about that. My grandfather passed away a few years ago, but I remember him using opioid for his pain. And he never had a substance use disorder. My grandmother, dealing with cancer pain now, she also uses that, right? And it's like the dose is really calculated and she has no substance use problem. So it's like, I don't want people to think ever, and we talk about it in pharmacy school, where like opioids are actually a really great treatment for pain, but I think it's problematic when it's not used for the right way. And I think there needs to be a historical context, I think, about opioid, because that's like the main issue that I think I see with the opioid crisis, at least. If one of you can provide a good historical context about how did this start and when did opioid become such a huge issue in Canada? Would anybody like to take that on?
How far back are you willing to go?
Okay, what you think would be most relevant and had the huge impact in terms of use?
I'll let you take the kind of arc, one of you two, with respect to the problematic use that we're seeing now. But I think my quick mention of even the Opium Wars and Opium Act of 1908 would be good to get us into the illegal status.
Do you want to do that?
So, from kind of 19th and early 20th century, there were concerns around opium, and again, recognition that criminalizing opium and its possession, its production, and its movement could be a useful means of social control. We saw a series of laws enacted in countries, around the world, largely thinking about the North American context. Here in Canada, we were at the forefront. The Opium Act of 1908 was, one of our first key drug laws. We had alcohol prohibition as well, of course. But the Opium Act of 1908, it did exactly what I've just said, making it the production, sale, use, possession of opium illegal, setting off, and we saw something similar happening in the United States, in different states around the same time, and subsequently federally, but setting off in many ways kind of the genesis of the war on drugs that we started to see. At that time, opium use was, relatively widespread. There were some concerns about its use at that period of time, but and then kind of across the population, the opium was readily available in different forms to the public. But many would suggest, and I'll look to others for comment here, that its criminalization at that point was less out of concern for its use and more out of concern for the population, subpopulations using it, in this instance specifically Chinese people. We had a large number of Chinese people who had been brought to Canada to build the Canadian Pacific Railroad, many of them settling on the west coast of the country following the completion of the railroad, and they were seen as competition to the largely white labor force, leading to race riots and the subsequent criminalization of opium and a targeting of people smoking, largely Chinese people smoking, and that's what we saw in the arrest statistics thereafter.
And I mean, just even a little bit further back, right, that stretch from the opium wars in China between the British and the Chinese, where explicitly the concern was not around the opium, but it was a political battle with the Chinese and the battle for territory. And the addressing opium was directly a means of social control. That, I mean, we've probably seen that there are sort of memes out there with like pictures of bottles with ingredients of opium and cocaine and cannabis where you can just buy off the shelves and give to your toddler for their teething pain. It's, I mean, we don't know exactly what the harms were associated with that. We weren't measuring it in the same way. There was certainly an element of intoxication, I think, that especially sort of pre-industrialization, that was tolerated in a different way. So we wouldn't have been able to sort of identify it in the ways that we would now. I mean, I think that really brings us to, I would say, if I would turn it over to you to speak around the sort of the modern sort of promotion of opiates as pain relief, and then the subsequent regulations.
Yeah, I think, and I don't know all of the dates, so I'm not going to use any dates, but I guess it was more in the 1990s where we did see the push from specific drug companies kind of promoting pain as the fifth vital sign, and the fact that opioids would be useful to treat acute pain and didn't carry an addictive potential. And so we saw this huge marketing push, and this led to overprescribing of opioids. And then kind of, I guess, like subsequently along this history journey, and especially in Ontario, we see the release of different types of opioid formulations, so long-acting formulations of Oxy-Neo. And so, or I guess it was Oxycontin, sorry, of Oxycontin. And then we see this kind of big rise in people being prescribed Oxycontin because, again, this is a long-acting opioid pain reliever. Because it's long-acting, people are not going to get addicted to it. And so there was this overprescribing. And as soon as they started seeing the effects of overprescribing, we see kind of the Ontario government pull that from the drug formulary. And so you can, when you look at these graphs, you see a rise in the prescription of Oxycontin, but then when it's taken off the formulary, so it's no longer available, we see this drop, but then we see an increase in people obtaining opioids from the streets. And so you can really see like the direct, I guess, like, or what happens or the consequences from drug policy, and then what happens kind of with patients at a population level, because we know if these opioids are not available for people who've become dependent on it, they're going to experience withdrawal symptoms, they're going to experience cravings, and so they will turn to an alternative source.
That's interesting. So you probably have patients now who are dealing with substance use disorder because of that campaign from Purdue Pharma, I believe, right? Yeah, and my fear would be, I know cannabis, obviously, I know there are studies out there, and you probably know better, like it doesn't have addictive properties, right? As much as, like, it's not something at the same level of opioid, right? But then why is it that people are coming now to CAMH for cannabis use disorder? Like, I remember having conversations with my peers around cannabis, and people were like, oh, it's legalized, now it's good to use, so people don't have that fear. But now look, people are coming to CAMH and using resources because they're using it every day. So what happened?
Well, I mean, partly addiction is a social issue, and how we perceive things to be addictive is socially related. But cannabis, I think, has always been addictive, and I think that in the battle for legalization, that went through the medicalization of cannabis. It sort of encouraged people to focus on the perceived benefits and the medical piece, and lessen the potential downsides of use. And so certainly I think it's unquestionable that there are a small number of people who use cannabis who have cannabis use disorder. I think that's true about nearly all drugs, actually. That most people who use a drug do not have a use disorder. I think that goes across the spectrum. It includes heroin, it includes cocaine. That people who use drugs generally do not have a use disorder. But that how many people use that drug sort of leads kind of directly to a certain percent of that population are going to have issues associated with it.
Okay. Interesting. Would you like to add to that?
No, I think great points made, and again, this lack of addictiveness of cannabis. People have often said it's not addictive. I'm a habitual user, and right. And I see Michael. Yeah, and you ask someone who's been a heavy cannabis user, what happens when you stop using? And it's like, oh, I wake up at night sweating, and I can't concentrate, and this, that, and the other. It's like well, those symptoms seem quite problematic, right? We haven't thought about them as an addiction, but that seems like something that. And that's part of it as well. That's kind of stopping use, but there are also the issues related to kind of the impact on mental health and relationship to psychosis that some people experience as well. That again, given the relationship to the rates of use, and how common cannabis is in our society, these are issues that we need to be paying attention to and to continue to do so, and not let the commercial entities in the space kind of negate those very real problems.
Yeah, thank you for that perspective. And just related to cannabis, and I know you work on adolescent population in your studies, what kind of message would you have for, let's say, a parent coming to you and they want to become educated, and it can be directed towards all of you, but because your research, Michael, is in that area, would you have for parents who are worried, let's say in Canada now, about the drug market out there, or cannabis being legalized so maybe their kids can have access, and if you can also give us a picture of who would be most at risk, if you're talking about at a population level, of the socioeconomic background, the race of that adolescent.
Yeah, I think it's a big question, and certainly the CAMH has lower risk cannabis use guidelines. And the first one I think is don't use cannabis, but one of the other ones is try and delay the onset of use. And that is often where the vulnerability to drugs happens, and there are pretty strong links between cannabis use and psychosis and schizophrenia, and other mental health disorders that is associated with cannabis use. So it's delay, and this other piece that. Also recommended by the Ontario Cannabis Store, so I'm not sure exactly about how effective it is, but it's the idea of being able to take a break. So we developed an app called Stop Cannabis Challenge, and it's basically that idea. It's like, can you stop? It's like, you're not addicted, show us, prove it. And even that period of like, taking a break from a substance, allowing your body to reset, often has a really beneficial effects both on your health and being able to come to more control over that substance use. You talked earlier, but you didn't like the word addiction.
Yeah.
And for me, what I really like around the word addiction is that it does not denote the idea of a substance use disorder.
Okay.
that for me, the word addiction is really about that loss of control and the loss of autonomy. And which is separate from sort of use of despite consequences. And I like that word, it's like being able for people to be able to reestablish that control. That drug use, I'd say almost all drug use that people use, I mean, there are drugs like nutmeg that is, gives you a really good high, but it is terrible after effects, right? So, I mean, there are tons of drugs. The ones that people use, they use them because they're good. And if you use them properly and you use them once or a few times and you get the right dose and the right setting, it's good, it's pleasurable, it's a positive experience, it can be a helpful thing. And then understanding, going from that base of goodness of that drug to where the consequences lie is being able to have control over that experience and being able to guidance and going through that experience that allows you to keep safe.
Okay. All right, before I open it up to the audience for Q&A, I wanted to ask this question and direct it towards Tianna, because this session was mainly focused on the stigma. And I think I hear this sometimes, people say addiction is a choice, or hearing that if they wanted to be fixed, they would, And so what would you say to someone who has that perspective to kind of just like open their mind?
Yeah. And I think a lot of people who face addiction also feel this way too. But I think, sometimes I talk to clients and yes, the first time they use a substance may have been a choice. But after that, kind of when we see that loss of control, a substance use disorder really is a disease of the brain. And it impacts that in so many ways. And so whether it's, trying to, they continue to use because otherwise they're going to feel unwell, or they're continuing to use because this is the way that they're going to either numb physical or emotional pain. There's usually something driving that use. And we live in a society right now where we just don't have the right framework to treat everything else that's usually going around, whether that be, unstable housing, especially in this city, unstable food resources for so many people living in poverty, et cetera. And so it really is not a choice anymore. And a lot of people that I work with, wish that they could do something different, wish that they can move past this, but just feel like sometimes that it feels like an impossibility in the current climate.
All right, thank you for that. And if you would like to add, but otherwise I would like to invite the audience to ask questions. Okay. Yeah, for sure, and the mic. Got the mic? Okay. And if you can introduce yourself and maybe a little bit about your background and then ask the question.
Thank you. Hello. Thank you to all the panelists and Satish for this amazing panel. My name is Tushar, and I'm a second-year medical student here at UofT, and I have a particular interest in addictions and substance use disorders, as is. And I think a lot of this panel really got me thinking back to what I've learned in class so far, how we approached it, and I think we have come a long way. We now have an addictions week, for example, in school, which is something that wasn't implemented just a couple of years ago. So there is an advance, but there are some questions that I have left. And so the first one here is about cannabis legalization. So we were fortunate enough to have a whole hour or two lecture on cannabis use disorder, which is something that they added relatively recently. But from what we were taught by the lecturer as well, is that now we're seeing different patterns of use as well when it comes to cannabis. Historically, it may have been more so of an experimental drug, and then afterwards a lot of people fell off and some people continued using it, but a lot of people just used it more so experimentally. But whereas now, maybe it's related to the medicalization of cannabis, as Dr. Chaitin mentioned, we're seeing a lot more older adults using it as well. And we know that there is an association with a lot of concerns, whether it be psychiatric concerns such as schizophrenia or pregnancy. So how can we advocate for both legalization and harm reduction at the same time, or also against the rampant commercialization, as someone here mentioned, just because I feel like that's often very lost in the discourse, and we end up saying that something is either harmful or legalized, and we don't really recognize the nuance between that. So how can, I guess, everyone advocate for that, and specifically like healthcare students and future healthcare professionals?
So, fantastic question. I think, with respect to cannabis, like the fact that there are older people now using, I think it's probably using once again. These are perhaps people who'd used when they were younger and stopped for a period of time, and so we've seen a growth amongst kind of middle-aged and a bit of an older population. A few things to kind of recognize. One, a small group of cannabis users are responsible for the greatest proportion of consumption. And so one of the concerns we want to watch for is what's happening there and ensuring that that's not growing too much. Benedict Fisher and colleagues published a pretty good piece, not pretty good piece, a very good piece a couple of months ago, kind of looking at the impacts of legalization from a health and public health perspective. And there are a lot of questions left unanswered based on the data that we have at the moment. So I think we need to continue to monitor this situation. But one of the things that I wanted to say, I was just reading a piece, I think it was the New York Times yesterday, around models of decriminalization, which I think we can, borrow some of the learnings from legalization. And as has been mentioned, we've got decriminalization on the West Coast now. Toronto's got an application for decriminalization, and we can look at a number of American states as well. And they're suffering a number of challenges there, undoubtedly. And many people have looked to the Portugal model as an example of great success. And I think we need to kind of compare and contrast some of the models. There are big kind of contextual differences, a national level versus kind of municipal level, and Vancouver and San Francisco being two places that people from across respective countries move to because of the kind of decent climates, people who are underhoused. But one of the key differences that was identified, at least in this New York Times piece, between what Portugal's done and what these other jurisdictions are done, are not only the continued kind of like fines and citations for people using caught in possession, so it's decriminalized, it's not illegal, but they still may be cited, but the increased pressure towards kind of treatment and supports that are provided, and those not being so readily available, or there being like great inconsistency with respect to the availability of those very supports that we would want people to be able to get access to help them with those issues. And so I think, without fully answering your question, one of the things that we need to consider as we move towards, as we consider not only cannabis legalization, but the legalization of potentially other substances as well, is the extent to which those supports are not only made available and properly funded, but whether people should be, and how strongly they should be encouraged towards those supports.
I mean, just to add on that, I think the other thing so I've made it clear that I'm sort of against commercialization. And I really think that that's something that should be avoided. I mean, we even look at the cannabis experience, and the things like rates of psychosis, hospitalizations to ER, the youth use, that what we saw was that in the period between legalization and probably pre-legalization, there was a delay before commercialization really set in. And it wasn't until commercialization set in that we started to see the problems associated with the health effects and the increase in use and dependence. And that is not surprising, that's what there should be good at. So corporations are very good at getting product to the people and being able to target the people, the small number of people who it's like less than 20% who use 80% of the product. That's like a standard rule, and so that's what they're trying to focus on. For other drugs, the other side of that coin is we also need to think about how to supply people recreationally effectively. If we don't want to do commercialization, which is a really efficient way of supplying people, we still need to be able to provide enough product. And in places like Uruguay, their cannabis legalization, I think, has been affected by they just don't have enough supply. And so that's kind of made it an issue. And I think it's also countries that try and go for a prescription model, people aren't willing to prescribe enough to be able to adequately supply. So those two considerations, I think, are important things to think about.
Thank you so much.
There's an organization out of the United Kingdom, Transform Drugs, and they've developed a number of, I think, very good guides on regulating different substances. And oftentimes it's a sliding scale based on the level of harm and the level of availability. That doesn't get to exactly how they will be made available and the role of pharmacists perhaps in that. But there are some very sensible approaches that have been proffered.
Thanks, Doug, for that great question. Yeah, I brought a lot of them.
It's a novel question. I suppose substance abuse involves pleasurable experiences, which is motivating. We're faced now with another epidemic called Ozempic, which has a very dramatic effect on appetite function. Do you know whether Ozempic users are also turned off of alcohol or other substances?
Yeah, there's literature looking right now at GLP-1 agonists and specifically the effect on alcohol. And so I think there's research not just on Ozempic, but other molecules that act similarly that are looking at that. So I think it'll be quite promising. We've actually had some clients on Ozempic who have an alcohol use disorder who've reported using less alcohol, but I think it's very much like just anecdotal, kind of what we're seeing, but like also not enough to write like a case report, because I think it's just very still in its infancy.
Very promising area, kind
Yeah.
of fascinating. Another question I had to do with some social hypocrisy that exists. There's a huge movement about social determinants of health and advocates of that, intervening early to maintain and support youth as they develop. But that group did not address the introduction of vaping, an opportunity area into a new domain, both of enterprise and use, where you'd think you'd hear something within the community, because you'd think there'd be advocacy in blocking, preventing, or modulating access to something that facilitates the use, like vaping, which is a growth area. Just wondering, how do you reconcile the social hypocrisy that exists, where you see the introduction of novel new opportunities, but not a concerted effort to modulate or address it in society that is devoted to social determinants of health?
So, I mean, vaping is an interesting topic, and it's one that I spend a lot of time on. I would say that the part of the thing that ties it back to social determinants of health is that initial stages of novel drugs are usually used by high SES populations. And then there's a social diffusion process that applies. And I think it's also true about drug use, is that use of drugs, sort of ever use of drugs, is often higher among higher socioeconomic groups. That, you know, if we think about the stereotype of the rich kids and cocaine, that alcohol is very strongly sort of a higher socioeconomic phenomenon. And so what we get the real hypocrisy here is that the use of drugs is sort of, we siphon off the problematic use of drugs and say, oh, this is a problem for poor people, essentially. So I can keep using my cocaine or whatever. I guess to bring it back, vaping, it's had the same issues as well, that it came in as a high socioeconomic things. I think there's some harm reduction elements and that are also associated with it. And I would say the other thing that really is that because it's new, I think there's too much attention on it compared to the old, like the harms associated with the continuing use of cigarettes.
Thank you, Dr. Angel, for that question. Thank you. And I was aware that there was an online question, so if you can show the online question, Joe, if that's okay. So I guess I can read that for the audience. The question says, I appreciate the reminder of regulated drugs, inclusive of alcohol and tobacco products, and legalization to criminalization. What takeaway points can be used to shift conversation in day-to-day? And thank you for the question, Kay. If anybody would like to tackle that question.
I'm going to sum up, I think, what Michael and I have both said, which is regulation is good, but we need to be very careful of commercialization. And we see this very clearly with respect to vaping, which we've just been talking about, right? Like the commercial interests associated with vaping and the way in which it is being promoted, much like smoking was previously, are key. So as we're slipping down the slope now. And as we move towards a seismic shift in drug policy, regulation will be key, and the presence of commercial interests. I'm someone who's benefited from the presence of commercial interests in the cannabis industry because they essentially funded our advocacy efforts to advocate for more equitable cannabis legalization. So I've got an interest, and I also think that the presence of commercial interests in these industries or fighting to get into the industries is able to move the government. Or provides, they spend lobbying money trying to lobby the government. So it moves the needle, but there are undoubtedly a host of negative consequences that come along with that involvement.
Okay, thank you for that. And I think maybe one more question and then, okay, we have 2 questions. And I just want to be aware of time, and we do have a naloxone training workshop after. But yes, if you would like to ask your questions first, and then we'll come to you.
So thank you so much for the wonderful discussion. This was really eye-opening and fantastic. So I went to high school in Ontario, and so I guess I'm sort of working off of what my own education experience was over here, where, we had grade 8 civics class, and they would talk about alcohol and drug use and tobacco, and what was really sort of pushed for us was an approach to it with abstinence. And I guess just sort of like branching off of the first question we kind of had, what sort of policy changes or governmental changes do you think can happen with regard to this shift with decriminalization and later legalization and then criminalization or decriminalization of substances?
I think more information, especially for young people, about both the harms and benefits and the reasons for use, right? Like I also went to school in Ontario. I had the VIP program where this police officer literally came in with, it wasn't a briefcase, it was like a binder with all these different substances and told us what they all were and told us that they were all harmful, like people say about the DARE program in the United States. No differentiation between the types of substances, what their harms and risks were. And one of the critiques of the DARE program, drug awareness resistance education, was that kids were told that cannabis was like heroin, and so a young person tries cannabis. Oh, that's not that bad. What do they then think about the other substances and the fact that they were lied to by someone who's supposed to be an important kind of figure? So I think that miseducation has done us a great disservice, and we need to be careful about, of course, availability and like the amount and type of information that people get generally, and young people in particular, but pretending that these substances are not there and painting them all with the same brush is not going to get us to where we want to be. A more sensible and the harm reduction approach that's been discussed earlier is perhaps a wiser one.
Yeah, I would say generally that school-based programs are really broadly ineffective at best. And that there's one of my colleagues did a study and found a school-based program that wasn't working, and looked a little deeper, and that in the schools where use was low, essentially what they were doing is they were coming in and providing, here are some things you might want to try. There are many of your peers think that these are great, right? And they taught them how to use drugs, essentially. And so they introduced them. They increase the availability and the awareness of those drugs. So school-based programs is not necessarily the key. I think it is we need gatekeepers to drugs and people and guides, like going back to kind of the way we've always used drugs, like the shaman or the spirit guide and the pharmacist, and throughout the ages there have always been people who have been assisting on that journey. Drug use is not something that people do on their own. and identifying who those modern age guides are and how we can gatekeep appropriately, I think is really going to be one of those challenges.
Thank you for ordering that. And we have one more question from Tutu, and then after that, I think we need to move over to the second part of the session, which is a naloxone training workshop by Tianna. So if you would like to stay, go ahead. And introduce yourself, please, and your field.
Good afternoon, everyone. My name is Otito. I'm a former pharmacist because I've pivoted to health policy. And the reason I did that was because I'm transformationist and I like action-related stuff. So I'm giving this introduction because it's related to my question. Now, I agree with you on commercialization. Now, there's a lot of talk about all what we've said today, but I want some action pieces. So I'm sorry to put you on the spot, but let's say the boss stops on your table, like you're the one to decide all of this. What does meaningful legalization entail? How do we do that? And how do we curtail commercialization?
So I'm really glad I'm not in charge of that. The way I'll just go my pet way, which is probably not right, and that's the idea of compassion clubs and regulated compassion clubs in a system that allows basically nonprofit distribution to members. With a system that allows sort of commercial sale to those compassion clubs to allow for adequate supply. So the combination of user-to-user experience, the non-profitness, so there's no incentive to increase use, no incentive to increase membership, along with the need for adequate supply. So that would be, it's probably not the right way to go, I would say, but that's what I would tell you today.
I like that. We submitted a contribution to the review of the Cannabis Act, and one of our proposals included a not-for-profit model to kind of alleviate some of the concerns around commercialization. I think one of the things that I would start with is repealing any of the remaining possession and even low-level trafficking elements from our criminal code as well to go along with what Michael said. But a shift is needed, and again, I think that there are models out there, and we're heading in that direction. But we certainly do need champions, and with the way that politics is going here and elsewhere, the extent to which we'll see meaningful change in the very near future, I think may be a little bit questionable. But we need to keep momentum heading in the right direction.
Okay, thank you for that. And I think was there one more question from the audience? Okay, and that will be our last one. And then I'm pretty sure we have to wrap up at this point.
Hi, I had a question about your thoughts on the new safe supply take-home programs. Of course, Canada is at the forefront of this. And I guess I wanted to know if you think that this is the right approach to harm reduction, and whether maybe it is a last resort because of the failure of our healthcare systems to care for individuals with addiction, and maybe if it takes away from the focus on recovery, maybe there's a risk of diversion. So I was curious to hear your thoughts about that.
Yeah, I mean, I think that this is a very hot topic right now and is quite polarized. There was an article that was just published by Tara Gomes and her group showing that safe supply, at least here, did not increase the risk of overdose deaths, and we're not necessarily seeing people dying more from hydromorphone and morphine, which is what's used in the safer supply programs. And so this was, I think, one of the biggest papers right now, I guess, to show that. And I think that that's been instrumental, because that's been, I think, one of the biggest arguments against safer supply, is that we are exposing people who would otherwise not have access to opioids to opioids. So I think that that's something that we have to think about and kind of use that evidence base. And then the concept of diversion, I think, is also a sticky point sometimes too. And I think especially in people, or the community of people who use drugs, diversion ends up being, a way to help friends. And also, in some ways, hydromorphone is safer, or at least we know what it is compared to what other people are buying. And so are we potentially helping protect people? And so I think there's many schools of thought on this, and is this exactly the right way? Are we kind of effectively decriminalizing drugs using the healthcare system instead of using more of a policy framework? But I think at least that paper really did demonstrate that right now it doesn't seem like we're doing more harm and perhaps doing some good with it.
Would you like to add anything, or we're good with that? Okay, perfect. I want to thank the panelists, so please join me in giving a round of applause. And I want to thank the audience, also the technical staff. Yo, thank you so much for supporting us, and also Massey College for providing the space. I think what I can always take away from lectures or talks about addiction or substance use disorder is that such a complex issue. There's like environmental factors, socioeconomical factors, and so I feel like the complexity just adds to the problem, and identifying the problem, going back to your point, Michael, is like, you know, identifying that problem and then solving it. So I feel like just being a junior fellow here and having the opportunity to discuss it with experts in the field is great, so I'm grateful for your time. And I hope that you also took away something from today's discussion and conversation. And in the YouTube video that is going to be uploaded, there's also a link that Tianna provided. And if you can just share, what is that video about?
For the naloxone training.
Yes, and if you're interested to stay, naloxone training, Tianna will go over that. But I guess that's just one way that as members of the society, we can maybe be part of the solution. So if you would like to stay, it's going to happen right now in this room. Otherwise, thank you for making it today. Thank you.